I just wanted to open today's CHAP CPD program with a special acknowledgement to our normal MC, Joyce Ramos, who's unfortunately unwell and can't make it today. So you've got me, and I'm actually really delighted to be hosting this final CPD session for the CHAP project this afternoon, because it gives me an opportunity to say thanks, and really to congratulate particularly the country cardiac rehab coordinators who've been loyal attendees at these sessions. So I hope you've got something from it. I know we've got national kudos for our Service of the Month sessions, and I particularly enjoyed those at the end of each day. And I just want to say that we've got a special little treat for Service of the Month session this year in line with our Christmas theme for this edition. So today we're going to talk about our journey to quality care and how we can improve measures. And so we've got the whole team here from CHAD to contribute to the lectures. That just makes it interesting, and you don't have to listen to me all afternoon. But also I think it's each person in our team has a strong area of practice. So you're actually hearing from the experts about the quality indicators that we're about to present. So next, we should acknowledge the country that the CHAP team, we acknowledge the CHAP team is spread across many of the traditional lands, and we'd like to pay respect to all traditional owners of these lands and those who are the custodial, who are under, and the lands who are under custodial lands. We are charged with nurturing and protecting country, and we pay our respect to elders past and present and emerging. Thank you. So, yep, that's what I was saying. Here's the awesome faces of our presenters today, and the whole team is here online. So I'm going to start with an introduction and an overview. So just a reminder for those of you who, I don't know, who've been living in a tree for the last 3 years, the CHAP project is about implementing evidence into practice for cardiac rehab in country South Australia. And as part of this body of evidence that we're implementing, there are guidelines and not guidelines in the practice that we are currently undertaking. Currently, there are no Australian guidelines for accreditation services. Lots of talk about that, both in CHAP and at national level. But there are well-established accreditation services for the quality evaluation of services in Europe and the US. So if you want to look at some of the standards that they put in place, I know we've been sending to some of you, but you could look at those. Although in 2021, we did put together the Australian Standardised Program, because there was quite a variation or heterogeneity in what programs delivered across Australia. And this was a major step forward, with a whole bunch of people from all over the country putting together 10 modules. And this was converted into manuals by the CHAP team with scripts and more detailed information, so that you guys could induct and train up-and-coming cardiac rehab folks with the standardized program, and keeping the whole team on quality practice. Then this year, we published the 10 quality indicators for Australia, and most of you will be aware of those. And they were the quality indicators that we've used to do the audit on the CATCH database to see how see how quality is being delivered through our cardiac rehab programs. Just a reminder that we have been collecting data in the CATCH database since 2011, and the CATCH database has been evolving then, and this audit that we conducted last year was part of the involvement of the CATCH database. And we've also been working very closely with the European accreditation body. I mentioned before in dot point 1, there are no benchmarks for the standards and quality indicators that the Australians have listed. So we'll look at those in a later presentation. And also the International Cardiac Practice registry has been established by the Canadian group. And at this stage, we don't have a national registry for cardiac rehab data, but it's something that's being talked about with the Solved guys. Next slide. So this is the standardized program, very familiar with that. And you can see from the next slide, these are the 10 areas that we should be covering in a standardized cardiac rehab program according to the national leaders of cardiac rehab. And all of this is evidence-based, underpinned by guidelines and core components. So we've got that covered in the manual. And next slide, these are the 10 quality indicators that we audited the CATCH database for just recently. And there needs to be evidence of referral, time to enrollment, comprehensive pre-assessment depression screening, assessment of smoking, assessment of medication adherence, exercise capacity, health-related quality of life, reassessment, and care transition, which is a discharge letter. And I was looking at some data that Alini was showing us this morning. Discharge letters are done really well. So congrats to everyone. That care transition is well covered in current practice. Next slide. Now, sorry, it's a bit blurry, but the Australian indicators did not tell us. So it says, yes, you have to do exercise, or yes, you need to measure depression, but it didn't actually provide benchmarks on how much a cardiac rehab program should reduce depression or increase exercise capacity, etc. So these quality indicators are from the Europeans, and this shows you the benchmarks of improving referral to 80%, improving enrollment, after discharge to 50%, making sure the median wait time for referral to start of cardiac rehab is within 14 to 28 days. I think we're actually achieving that from the latest data I've seen, etc. A pre-assessment and a post-assessment. And you'll notice that there's lipids and BSLs there, or HbA1cs, and they've also got anxiety and depression in this one, and muscle strength. So we were using these plus the Australian ones to audit the CATCH database to look at what quality indicators were missing. Next slide. Also, when we were looking for evidence for practice, we realized that there were things like the health-related quality of life and medication adherence not being collected in the CATCH database. So we looked at the core component data evidence from around the world to see what tools should be used to collect this data. The Australian core components were published in 2014, so they've been around for a while, and there's a load of tools. So if you use depression as an example, the most popular tools around Australia at the moment for measuring depression and anxiety are the HADS, which measures both, the PHQ-2 and 9, which measures depression, and the K10, which measures anxiety and depression together. So they're all recommended in the core components. So if you're looking for tools, that's where you would go to find out how to measure the quality indicators in cardiac rehab. But again, the benchmarks were not, thanks, Alini, are not really stated so explicitly in the Australian core components. There are percentages there that should be measured. So next. So congratulations, everyone, because the CATCH database was actually fantastic and a fine example of measuring the quality of cardiac rehab practice. However, we did find that there were 4 quality indicators that were missing, and they were pretty important. They were muscle strength, anxiety, medication adherence, and health-related quality of life. And we've got all our experts here. The guys from CATCH and ICCNet will remember we had loads of robust discussions about which of the tools we should select to measure these. And after lots of discussion and further research by our team looking at which ones were free, which ones didn't require a license. And I don't know if you realize that but a lot of tools like the SF-36 and the Minnesota and the Kansas City heart failures quality of life tools and the Marinsky medication adherence. What can I say? They have licensed police checking publications, and if you mention that you use them and you didn't pay for a license, you're going to be in big trouble. So the licensing police will come and find you, and you'll get fined or you'll get charged for using the license without paying them. And another feedback from my favorite cardiac rehab nurse, Jess Maddock, was that they need to be short. We can't take an hour to measure quality of life. And there are tools that probably would take an hour, which is like the SF-36, which is a health-related quality of life tool that has 36 questions. They have been used in research, but we got really good feedback to say they probably wouldn't translate well into routine clinical practice. So short is good. And they should be validated. There should be evidence around to say that they're being used in routine clinical practice. So we did that, and the tools that we've chosen are routinely used in cardiac care. And that's what I'm saying, national practice. So with the anxiety tool, we are also recommending the GAD-7, just 7 quick questions about anxiety, because the PHQ-2 and 9 don't measure anxiety. But our colleagues at Monash, which is going to be the center of the universe for heart care, are using the GAD-7. So that was a good endorsement for us to follow practice. And maybe in the future, we'll be able to compare outcomes. So I'll just quickly talk about muscle strength, because Joy's not here today. And the sit-stand test is the one we've agreed upon. It can be done in 30 seconds. So I'll probably skip the video, but you can come back to that later and click. If you Google sit-stand step, there's about at least 20 versions that you can conduct remotely or face-to-face. A new one that I saw in the last review was you just do 5 sit-stands and measure the time, and then you replicate that into 30 seconds or 1 minute. So that could be a quicker way to do it. We also had concerns about the safety of the sit-stand, particularly over the phone. So we contacted ESSA, the Exercise Scientists of Australia, and they had it already covered. And they had a 6-point safety check before you would conduct a sit-stand check. And the guys at ICCNet are recommending that there should be someone there with them, which I think is fine, or you could have a video of the sit-stand test being played. Now, the sit-stand test, I'm just raising the flag, I think will become a really important part of practice in the future, because because it measures muscle strength, it also measures frailty, which you probably figured already if you didn't already know. And frailty is a major indicator of outcomes in heart failure. So the more and more research is coming through to say heart failure patients should be assessed for frailty, and that frail heart failure patients are not going to have as good outcomes as the not so frail. However, the good news is that frailty can be reversed. That's great news. So you guys, amazing physios and cardiac rehab scientists, you guys could make a major contribution by knowing muscle strength and identifying frailty and saying, well, come on, Joe, we need to get those muscles in good shape. So I'll hand over now to Eleni to talk about why the anxiety tool and why we chose it. Thanks, Eleni.
Oh, thanks, Robin. So the anxiety tools that you will be using in the CATCH database and in CATCH Web is the generalized anxiety disorder, popularly known as GAD-7. It was designed primarily as a screening and severity measure for generalized anxiety disorder, but it performs very well for other types of anxiety disorders, such as panic disorder, social anxiety, and post-traumatic stress disorder as well. So it is actually a a node tool, which was created and paid for by a pharmaceutical company. I don't remember which one now, but it's now free. And the good news is that it's been validated all over the clinical spectrum and in many countries, and especially for primary care patients, for the general population, and also for adolescents. So this is a meta-analysis which looked at the effect of exercise-based cardiac rehab on anxiety and depression in patients with myocardial infarction. And this is one of the reasons that we know that in cardiac rehab, we should be measuring anxiety, and we should be counseling patients if it's appropriate. And it's because, as you can see here in this diamond-shaped forms, that cardiac rehab can contribute to lowering anxiety and depression in patients with myocardial infarction, which is great news for us. And this, through this, you can see the effect of cardiac rehab at different time points as well. So it reduces in the anxiety in the short term, as we would expect, but the effects can last longer. So it was tested up to 12 months with a significant reduction. So it is important to measure and to counsel patients around anxiety. And as Robin said, anxiety is included in most of the quality indicators, both in Australia and internationally. So the Europeans, in specific, they say that anxiety and depression, it's expected that the cardiac rehab program will improve them by 10% by the end. So this is another reason for measuring. So the GET7 is a pretty simple tool, as you can see. Of course, it has 7 questions, and you will be able to score your patient's response from 0 to 3. And then it's a simple sum. So you just add up the response to have the final score. So it can be self-assessed. It only takes 1 to 2 minutes. If the score, so traditionally the scores have been stratified as up to 5, and then 5 to 10, 10 to 15, and above. So this represent significant cut points for mild, moderate, and severe anxiety. But more recently, the recommended cut point has changed after some more research and meta-analysis around it, showing that actually a score from 8 to 10 is closely related to having generalized anxiety disorder. So it would be more sensitive. You would be getting more patients and earlier, detecting anxiety earlier, using a score of 8 rather than 10, which was previously used. So there are recommendations, clear recommendations according to the score. So if the score is 0 to 4, you don't need to do any further follow-up on this. If it's 5 to 7, the anxiety is deemed to be mild, and you just have to monitor symptoms and follow up. So 8 to 9 also mild, but you should repeat the GET7 every 4 weeks, because there is an increased risk that it will turn into a moderate or severe anxiety disorder. And so from 10, you actually should be referring your patients for some mental health professional. And of course, from 15, this is a severe disease. So these are some references in regards to that 7, if you are interested. And I will now hand over to Lem to talk about medication adherence.
Thank you very much, Alini. So further to the quality indicators, one of them, as you know, is medication adherence. So I will not bore you with lots of information about things that you already know. So I will go past to the instrument itself, why we chose it. So several tools are available, as you know, for medication adherence, like Robin mentioned, more risky, which is risky to use without permission, or you need to pay the cost. But it was validated for other chronic diseases as well, not specifically for cardiac patients. And it might also take more time and impractical to use, especially with the longer ones, the longer, more risky tools. So we chose the adherence to chronic disease scale, which is SCDS 7. It has 7 items. And why we chose that is it is validated in cardiac patients, coronary artery disease patients. It's free to use. We have received permission from the author specifically to use it in clinical practice of CACH or any clinical practice in Australia. And as I said, it has only 7 multiple questions, which will not take time, and it's easy to interpret the scores as well. Next, please. So this is the tool. So it has 7 questions with multiple choice, and it's just to circle the answer what you think is appropriate for the patient, or when you feel it, or the patient itself. So the good thing about this tool is it addresses the patient factor and also the prescriber's factor to some extent, so that it will be good to just target what things or factors you need to address for the patient according to the response of the questionnaire. Next is the scoring. In total, you will have 28 points. So the score is when the patient answers multiple choice A, it will be scored 4, when it's B 3, C 2, D is 1, and E is 0 score. So the total score of less than 21 points will be classified as low adherence. And when the score is 21 to 26, it will be medium adherence. When it's above 26, it will be high adherence. So depending on the type of question and the answer they give, you can just target what you can work on with the patient so that improvement of adherence will be achieved on specific patients. So the great news about this tool is it has been embedded in the CACH web as well as the CACH database. So anytime you are following up your patients, you can just grab the instrument and measure how your patient is working on with their adherence. Are they following the information that you guys provided for them? Is there any more information that you need to give or follow up with the patient so that they will have the quality they need for medication adherence? And I think that's all. Thank you very much.
So I'll then
sorry, I will introduce the next presenter. That's Dr. Noma. She will talk about the quality of life tool that we embedded as a quality indicator.
Norma, you're on mute. Norma, you're on mute.
Sorry about that. Thank you, Lem. I'll just take us through the EQ5D5L, which is the quality of life measure that has been embedded in the study. So the EQ5D is one of the most widely used and validated health-related quality of life measures, and it comprises 2 parts. It has a descriptive system, which assesses health across 5 dimensions, that is mobility, self-care, usual activities, pain or discomfort, and anxiety or depression. This part of the EQ5D questionnaire provides a descriptive profile that can be used to generate a health state profile for any individual who completes it. The second part of the EQ5D is a scoring algorithm that assigns a summary index or weight for each health state generated. The index scores are sometimes referred to as utilities, are based on a societal preference weights for the given health state that will have been generated in the first part. The health state index score generally ranges from 0, which is equivalent to a health state of being dead, while negative values represent values that are worse than dead, and 1 is representing full health, with higher scores therefore indicating higher health utility. The utilities are not generally used in clinical care because they are only computed for research purposes, and they help us in generating quality adjusted life years for use in health economic analysis. So in routine care, the next slide shows us what the patient receives. So this is the questionnaire that the patient receives, and they're able to tick for each of these dimensions or domains. They're able to tick which one best describes how they are feeling within the last 7 days. I think the other thing I need to mention is that there are 2 versions of the EQ5D, the 3-level version and the 5-level version. What we're using is the 5-level version, which is newer and apparently is supposed to be more sensitive to change. In the 3-level version, it means that there are only 3 options under each dimension. But in the 5-level version, those options have been increased to 5, such that the instrument can be more sensitive to change. With the 3-level version, studies found that there are ceiling effects, in that patients often reported themselves to be at the highest level because there were no other options in between. So that's how the 5-level version came to be developed. So what we are having is the 5-level version. Patient ticks what they think is most appropriately represents how they felt in the last 7 days. And then next, they also tick what we call the visual analog scale. And on this, they basically state on a scale of 0 to 100 how they feel on that day. So all they have to do is to tick on that scale and to also indicate the number that best describes what they have ticked on the scale. Next, please. So then how do we interpret the results that we get from the EQ5D? Now, in the clinic setting, all you will see on the patient's report are these numbers. No problems, there is assigned a response of 1, slight problems is 2, moderate problems is 3, severe problems is 4, and extreme problems is 5. So what we need to know is that a 5 is for worse, for someone feeling worse than someone who reports a 1. And usually what you see for each of the dimensions is either of these numbers. So a patient in health state 1, 2, 3, 4, 5 will then have no problems with mobility, slight problems with self-care, moderate problems with doing usual activities, severe pain or discomfort, and extreme anxiety or depression, because for anxiety, they've reported a 5. So in interpreting what we see in the clinic is to just know that a 5 means they are worse off than someone who has a 1, because for us to generate the utility scores, we would have to analyze the data first. So each health state is then potentially assigned a utility score based on a scoring algorithm, which is generated from a general population sample. So in the clinic, all we have to look at is which of these levels the patient has reported previously, and then at the next appointment, and see if the numbers are getting bigger, then the patient is getting worse for that particular domain. If the numbers are getting smaller, then the patient is getting better for that particular domain. Thank you.
I'm on mute now, sorry. Okay, everyone. So that's our 4 tools that we've updated the CATCH database with. My understanding, I think Nicola's online. They're all active and ready to go, Nicola, is that right? Perhaps we could stop slide sharing and all turn on our cameras now so we can have a few questions or discussion. Nicola, they're all the...
Turn on my camera, hang on.
Yeah, thanks.
Oh, there we go.
Beautiful, beautiful.
Tracy's here as well.
Oh, hi, Tracy.
Yeah, so all of the quality indicators are on the database now, and we're using them.
That's a terrific outcome. That means that we're now collecting data for quality assessment at international standards. So that's great. That's great. So Nicola, let's share some conversation about the sit stand, because that was one that caused some concern amongst telephone nurses in particular. And tell us about how you've implemented it and also maintained safe practice.
So the barrier that we face being a telephone program is a lot of patients are either they're often reluctant or don't have the capability to do the video conferencing, which is a barrier to performing the sit stand. So that's probably the only quality indicator that we haven't had good uptake on for that reason. And also a lot of our patients will conduct their exercise calls maybe when they're out and about or they're home alone, and it's just not an appropriate time or safe sort of situation for them to be in and for us to be in as clinicians as well. So yeah,
and that's fair enough. That's good safe practice. And then we've got the ESSA guidelines for everyone to use, so they would do that like in the gym before they started this
face-to-face cardiac rehab program. Then they'll be doing the sit to stand assessments, I presume, in those programs. I think it would only be an issue with our telephone program.
And Frank, do you do hand grips or sit stands?
Do the sit stands and the 6-minute walk test.
Yeah. Okay, cool. Very good. Very good. And Nicola, any other feedback or experiences with the other? Because I know that the original CHAP, or actually this is a good one for Tracy. I don't know how to say this. I mean this affectionately, Tracy. You've been around for a while. And so in the old medication adherence, it was just, are you taking your meds? It was a simple, straight out question. How do you feel about the extra questions that are a little bit more inquiring, and how are the patients responding to that?
Well, they're responding okay to it. There's as far as going through every single question, one of them I was just saying to Nicola a moment ago about the one about the GPs.
Do you tell the truth to the GP?
About your medication. We're saying quite often, the GPs won't. You'll get they won't ask unless it's a new medication, perhaps, or they might say how you're going with your tablets or something. So some patients will say no, doesn't ask me ever, sort of thing. But going through, I go through and ask them. They're answering the questions, most of them. But that's the main question that I find a bit awkward, and I just wondered. There's a couple, and the one about whether you speak to your GP, you feel comfortable speaking to your GP.
If you look at the tool, most of it's
I think it's quite direct sometimes. If you're asking them sort of verbatim, question by question, it could come across as a bit sort of blunt. And I guess as nurses, we have to use our words to communicate that without causing any offence or making any kind of assumptions that perhaps they're not being truthful, or we don't want to sort of damage that rapport we've built up with them.
Frank, how would you do it face to face? Do you think it would be uncomfortable to say, do you tell the truth to the GP, or?
No, definitely not. Once you've built a rapport with them, I think it wouldn't be an issue. And the wonderful thing about these indicators is that you do have that initial and then that post assessment and comparison. And something like this one, the medication, in regards to do you find all your medications necessary for your health? I mean, I think that'd be answered very differently from the start of the session to conclusion of the session, and hopefully that'll be highlighted as we start to really collect this data.
Yeah, and my experience with the CHAP study with the heart failure patients is they actually pick up clues from these questionnaires. They go, oh, so she's on to me about telling the truth to the GP. All right, they're on to us. So maybe I should start telling the truth. Yeah.
Especially with the diuretics, yes.
Yeah. And I think we had a lot of discussion about the anxiety and depression. So what we were doing was PHQ2, or what is in practice is PHQ 2 and 9, which is actually 11 questions. And on investigation, that would have come from Beyond Blue, probably in the last 5 years. Beyond Blue have changed to the K10, which is one less question, but it's a combined anxiety and depression score. And I'm not sure, Nicola, if you were there in the team at the time, but I know Tracy was. We had lots of talk about PHQ2 and 9 were well embedded into practice and everyone was comfortable about them. So everyone sort of agreed that we could add some more questions about anxiety, so we've got it covered. And I think you guys will give me feedback, but I think the one thing you can almost cure is anxiety with cardiac rehab. I mean, the scores must go through the roof. So now I'm looking forward to seeing how the scores change pre and post, because I think, I think you will just have these wonderful quality outcomes that will show, look, the one thing you can cure with cardiac rehab, telephone or face-to-face, is anxiety. And the reason I say that with confidence is our beautiful Ali Kraulik. I remember her talking and saying, did you remember that, Frank, when she was at one of our seminars, she gave a talk and she just was so anxious at discharge. And then after her rehab, she was really confident and self-caring. Do you agree, Frank?
Absolutely. Yes.
Yeah. Oh. Yeah. Okay, open questions, even from the team. Any thoughts or feedback on our experience to achieve international standing? All right, we'll finish the last 5 minutes with a bit of fun then. So if we can have the slides back up. I'm glad you're here, Frank and Nicola and Tracy. Okay, next slide. So some drum roll, ta-da. Next slide. So we've decided to give Service of the Month awards from the CHAP team. And I would like to say that there are gifts in the mail to all of the winners from today. And we've reflected over the years about the different, let's say, characters in country cardiac rehab, particular country and metro. And these awards are what we've come up with. So please enjoy. So drum roll. For Excellence in Communication Award, we would like to, that's for sure, the Whyalla Better Care team. So Whyalla Better Care team, there's some CHAP coffee cups and chocolates and a certificate for you to frame and put on the ward from us. So the next award is Making the Most of Technology Award. Oh yeah, that's what we're all about. And the winner of Making the Most of Technology Award goes to the Barry Better Care team. Yay, Barry. Okay, Barry, you've got some chocolates and coffee cups on the way in the mail. So well done. And obviously Barry needs to be on top of their tech. They're really good at that. They had that amazing, what have they got? I can't remember.
Tablets and Health Direct.
That's right.
Calls,
yeah, their system with Medicare Direct. Oh my God. The Fantastic Follow-Up Award. The Fantastic Follow-Up Award goes to Murray Bridge, and we have an amazing consumer from Murray Bridge Better Care working with us. So she's been helping us with our seminar. So well done to Murray Bridge, great team out there. The next award, the High Cardiac Rehab Program Completion Rate Award. Okay, this is coming from the data, so you might not even know who this is. I don't actually. Who's got the highest completion rate? I see that. Congratulations, Nicola, Trace. You knew that. Yeah. All right. Well done. There's a whole bunch of coffee cups and chocolates on their way, team. The Everyday Hero Award. I wonder who this is. The Everyday Hero Award goes to Mount Gambier, Frank. Well done, Frank. I think that you got that award because you've been doing this job for quite a while now. So you're a hero to all of the folks that you've been caring for in Mount Gambier. Well done. Chocolates and coffee cups in the mail on their way to you. And the final award, whoa, the Ultimate Team Award. The Ultimate Team Award goes to Flinders Medical Centre Cardiac Rehab Team. And boy, they've had a tough couple of years, no doubt about it. Those poor guys packing up their gym, turning it into a PPE change room, unpacking their gym, rolling out the exercise machines every week, implementing original and unique models of care. They're amazing. So well done to Flinders Medical Team. And keeping people out of hospital ward, that's got to come from the data. That goes to Port Lincoln Better Care. Well done, Port Lincoln Better Care. That's a great award. That should be worth money. I talked to SA Health about that. And there's chocolates and coffee cups on the way to you guys. The Timely Post-Discharge Review Awards. So well done. Goes to Royal Adelaide Hospital. So you guys have got the best referral rates and discharge letters going out there to the cardiac rehab services. So well done to Royal Adelaide team. Haven't seen you guys for a while. And supporting women's health, Alini must have nominated this one. Lyle McEwen Hospital, obviously Sue Serp and Margaret Astle and the Coffee Club that they've got going up there, and the amazing data that they're producing for cardiac rehab, especially for women. Well done, Larmac. Chocolates and coffee cups on their way to you. So, well, that was a bit of fun. That was great. So, well done, Frank. Well done, Nicola. Well done, everyone, for your awards. When you leave the meeting today, the evaluation form should pop up. So please give us feedback. It's a bit sad to say this is the end of our CPD program. We are hoping to have a data workshop next year based on the 5-year audit that we're putting together over the next few weeks. So we'll come together and see if we can improve data collection, data burden, and I think we've already achieved international standing. So it's just a matter of streamlining the burden of data collection that I totally understand you have at the moment, and maybe improve reporting back to you. So there will be reports coming your way very soon, I promise, in the new year. Also, I spoke to Saline. She's got the community of practice going, and Cardiac's Heart Foundation are having more seminars. There won't be no seminars next year, but the program itself, as you're used to, will be completing today. So have a great Christmas, everyone. Thanks for your commitment and attendance. And yes, thank you. Thanks a lot.